welcome to Compass Pal Conversations, the space where we talk openly about living fully, caring deeply, and finding meaning even in life's most tender moments. And today's guest is Tracey Piparo, who is based in New Jersey, USA. She's a physician associate with over 20 years in healthcare, and she's all about helping people face serious illness and feel empowered in their care. She is passionate about making it easier to talk about death and dying, and she believes that everyone deserves compassionate support at the end of life. Through her speaking and her advocacy work and her role with the National Emergency and Palliative Medicine Initiative of Compassion and Choices, Tracy's help Tracy's helping bring more heart and humanity into healthcare. So thank you, Tracy, for joining me today. I am so honored to have you. I've been so impressed. Ever since I came across you on LinkedIn, I've been so impressed with your work. It's always great to find other people who are as passionate or even more passionate than me about palliative care and helping people to die well as live well. So thanks for being here.
Yeah, thank you so much. This is awesome to make this happen. I'm super excited.
Awesome. Thank you. So before we dive in, can you share what drew you to end of life care?
Yeah, wow. I feel like it was a process to get here. I've been a PA for almost 25 years now. I started out in emergency medicine. Um, I was an adrenaline junkie. I knew from the minute I went into medicine that I wanted to do the ER, and I did that for a really long time, almost 17 years. And kind of started backing off of that lifestyle after two kids and did a little bit of hospital medicine and realized, like, wow, we're doing a lot of things to people down in the ER and in the hospital in general, and nobody's asking them if that's what they want. And I started having those conversations more with folks and kind of interacted with our palliative care team that we had and was like, wow, this is a total aspect of medicine that no one ever told me about. I never learned about this in school. And I just never really thought about like what happens to people when, they don't want to have all these things done, or there is, you know, really difficult things happening, who talks to them? And I realized that it was kind of my jam. Like
Mhm.
I was in a space that filled my cup when I did these things. And I'm like, how do I get myself to do this more? And that's when I really, made the switch and was like, I want to get a job doing this all the time.
Mhm.
And really awesome PAs that are in palliative care and hooked up with PAs in hospice and palliative medicine, PAHPM, which is our national organization,
Mhm.
and just applied and waited around until I got a palliative care job. So I've been doing that for years now, inpatient, and
Mhm.
it's like every day is exhausting, but it's
Mhm.
a good thing because it's totally filling my cup and it reinvigorated like my love of medicine.
Okay. Yeah, that's awesome. It sounds similar to my story, except for the ER part, because I'm not an adrenaline junkie when it comes to medicine at all. But I definitely can relate to, it's almost like having that aha moment where you recognize that, okay, this is what, as you said, fills your cup. And
Yeah.
yeah, I can totally relate to that. And I think that that is an awesome, I think that's an awesome beginning for you
Mm.
because you started in something that was, very, very different. And now here you are and changing lives by it.
Yeah.
So, mhm,
To now, because my team has developed this initiative where I'm spending more time in the ER now,
mhm,
working ER docs and residents and trying to bring palliative to the ER. So we're meeting these people really early that need, aggressive symptom management, you know, talks that could change a disposition, keep people out of the ICU if that's not where they want to be. So like it's gone full circle and I get to be back down where I started.
Yeah, and I that's also an initiative that we have been trying to do here in Barbados as well, because it is so important for ER doctors and nurses and all the staff to understand something about palliative care, right? Because you are the first point of contact usually for a
Right.
patient who comes into hospital. So you need to be able to meet them where they are and help them in the way that they need to be helped, because it is, I keep saying this all the time, it's so different from a patient who is not palliative, right?
Right.
The treatment plan cannot be superimposed from one to the other. So it's really important to have that, at least that little bit of knowledge, so that you know, okay, where do I go from here?
Yeah, absolutely.
Yeah. So, how would you say you've seen the culture shift over the last 2 decades as it relates to conversations around death and dying?
Yeah, I think historically there's been so much that has been, the conversations have been very paternalistic. You go to the doctor, they tell you what they're going to do to fix whatever problem you have presented to them.
Mhm.
And as a patient, you just say, okay, fine. And people have started to question more. And
Mhm.
for me, I think it's great because it kind of takes some people down a notch where, like you said, you have to meet them where they're at, right? You take away that hierarchy. Like we all have our talents. Um, Medicine just happens to be the talent of us, right?
Mhm.
Share that with people, but it doesn't make us any better or less than the people. So I've definitely seen a shift from just blanket acceptance of whatever your healthcare team says to more
Mhm.
questions. Um, Sometimes I think it's gotten a little much with Google and people looking things up and, and having a lot of mistrust system. But when I see people who hear like they're not trusting what I'm saying or not trusting what another member of the healthcare team is saying, I always have to kind of take a step back and say, where is that coming from? Because a lot
Mhm.
of times I think it's really coming from a place of fear
Yeah.
because for anybody, you know, even in medicine, like you can encounter things for the first time. But for most patients and loved ones, this is happening to them for the first time. They've never had cancer before, or
Mhm.
they have had congestive heart failure before, or their mom has never been in the ICU before. It may be the 50th mom I've seen that week, but this is their mom for the first time in the ICU.
Mhm.
So I think the big shift has been people and advocating for themselves more and maybe forcing the healthcare providers to actually explain more. And I think that's what sometimes we need to do better is to meet people at their level of understanding and be able to explain how what we want to do is going to marry with what their goals are. Um, and I think that's going to continue the shift. I keep saying, especially in the world of palliative, patients and families just need to keep asking for the support of palliative because it's going to force the healthcare system, other services, other providers to keep using the resources of their palliative care teams. Um,
Mhm.
because it's people are going to drive the change. That's where it's going to come from.
Yeah. And what I wonder as well, well, for your setting, because I know how it is in Barbados, how comfortable are non-palliative doctors with having those conversations with patients? Because it's a major
I,
problem.
yeah, yeah, no, I think it runs the gamut. Um, I have some colleagues outside of palliative who are very comfortable being honest with their patients and loved ones and saying, listen, I'm really worried. In my opinion, if I can just get a colleague to use a worry statement, just be like, I'm really worried we're not going to get there. Or even to just ask a patient, you have patients, I just want to get make me better. Well, don't say yes unless you know what better means for that person.
Mm-hmm.
Otherwise, saying yes, you don't know what you're promising.
Yeah.
Um, so it is very difficult. And I keep saying I think it would be great if more healthcare providers had awesome primary palliative care skills.
Mm-hmm.
If you can't do that, if that's not your thing, you at least need to know where to get. You need to be able to identify conversations have to happen. And then I use the example of, I don't know if you got the Staples commercial up here. It's like you hit the easy button because Staples has everything that you need. I'm like, you just have to hit that easy button because the palliative care team is there. Will help
Mm-hmm.
you
Mm-hmm.
uh, heal your patients. I it's, the big deal here is a lot of people say, oh, now they're going to be on palliative and I'm not going to do anything. And I'm like, no, I don't want to steal your patient. I want to you can still do your thing if that's what they want. I'm just going to kind of help out and make sure they're doing okay while you do your thing.
Yeah, that is what I have experienced a lot of, where there's this fear that I'm trying to steal your patient. I don't want to steal your patient. I want you to continue. This is
Yep.
teamwork. Teamwork
Hmm.
makes the dream work, you know? Ugh.
Absolutely.
So it's
I'm glad
interesting that you mentioned that.
here. I'm glad it happens everywhere.
Okay, so the whole purpose of this podcast episode is to talk about advanced care planning.
Hmm.
So lots of people have heard the term, some people even use it, but without really understanding what it means. So can you give us a little bit insight into exactly what advanced care planning is?
Yeah, advanced care planning is really thinking about what would be important to you if you were closer to the end of life or if you were facing a serious, potentially life-limiting illness. I recognize it is impossible to anticipate every single thing that may bring you closer to the end of life. But I believe that deep down inside of everyone, they have thoughts that if they had a choice, how would I want that to look if I was closer to the end of life? So it's the thought of being able to think about it, but then more importantly, picking a person to talk to about it. Because if you keep it to yourself, nobody else knows.
Mm-hmm.
And I do. When you are closer to the end of life, the likelihood is that you are confused or sleepy or not in a place that you may be able to share all that information with everybody,
Mm-hmm.
despite best efforts. So for me, the number under the advanced care planning umbrella that I call it, um, is a healthcare proxy.
Mm-hmm.
You have to identify somebody that if you cannot have a conversation with your healthcare team, there needs to be a person that knows you the best, that you have shared your feelings with, that can talk to your team and help make decisions related to your care.
Mm-hmm.
Um, but you also have to let that person know that they're a proxy and share those thoughts with them because that can happen where we'll find a healthcare proxy and they're like, oh, I had no idea that they picked me.
That's hilarious.
Yeah.
Yeah.
So that is, that's, advanced care planning has this big umbrella. Everybody talks about, living wills or,
Mm-hmm.
healthcare durable power of attorneys, um, durable, there's so many names, but the biggest thing is just think about how you would want your end of life to look and
Mm-hmm.
share that with somebody.
Yeah. That's you're absolutely right. And you mentioned about wanting to have those conversations before you're nearing the end of life when you are drowsy or out of it and so on. And it's also important to have those conversations before a crisis happens.
Hmm.
Because in those moments, nobody's thinking straight. Everything goes out the window,
Right.
so it's really important that everybody is on board and the people who are on board know that they're on board.
Yeah. Yeah. And I think, it's all shaped by your values and
Mhm,
advance can change over time. For example, my husband and I have done advanced care planning, we have healthcare proxies, we have, advanced directives, but we're healthy. We don't have any, big diagnoses. If that were to change, I would probably change some things that I have written down, or I would probably say some different things to my husband, my family to say, okay, I'm in a different place now, right?
mhm,
It- if I walked outside right now and had a massive cardiac event and my heart stopped, I would expect someone to do CPR on me.
mhm,
Like,
mhm.
okay with that. I'm okay with taking the chance and see how I am on the other side. But if at some point I am at the point where I have, metastatic cancer or a diagnosis of some other, degenerative neurological disease, lots of things, maybe if one day I walked outside and my heart stopped, that would be okay. And I would be okay with not doing CPR. So it can change over time. Conversations have to be, we have to all get to a place where it's so comfortable to talk about it that we talk about it often when it's necessary to change our ideas.
Yeah. And it's a plan and plans change.
Yep,
So it's okay for it to be different from week to week, month to month, year to year, right?
absolutely.
And then the important thing, as you said, is to be comfortable enough to just have the conversations. I think
Yeah.
what a lot of people don't realize is just because you're having a conversation about what you would want doesn't mean that you're calling death on you, right?
Oh my God.
It's gonna happen. So
Yes.
wouldn't you want to
I
be prepared?
I see that so much, especially here, even it seems to be like very typical of certain generations where it's like,
Mhm.
I'm not gonna you're gonna make me talk about that and then it's gonna happen. And I'm like, well, I wish I had a superpower like that, but I'm pretty sure it happened. But again, as my friend General Brian says, like, it's definitely gonna happen. Like death is the only thing 100% successful, right? It's
Correct.
gonna happen. Some of us just get the opportunity to say, hey, this is how I would want it to be if I knew it was coming sooner than
Mhm.
than later. Um, So I think it's yeah, I agree with you. It's having that conversation over and over again as things change and also recognizing, I share with a lot of loved ones whose people may have not spoken to them about it. It's not so much a decision that you're making if you have these conversations beforehand, you
Mhm.
know? If you let your person know what's important
Mhm.
to you, then my job as the healthcare person, as the palliative care person, is to say to your loved ones, tell me about your person. Tell me what's important to them. Tell me what matters to them. And then marry that with what is available from our medical stuff and
Mhm.
say, you can do this, but this is how it's going to affect what's important to them. And it doesn't become so much a right or wrong. It's the best thing for that person. There's
Yep.
no, oh my goodness, I did the right thing. I'm afraid of doing the wrong thing. I hear that so much from people. I'm sure you hear that all the time. I,
Yes.
I don't want to pick the wrong answer. And I'm like, there's no wrong answer. It's the best for your person.
Mhm. Yeah. You're absolutely right. And the next thing that I was going to segue into is the biggest myths or misconceptions that you hear about advanced care planning. So we just talked about
Hmm.
one of them, which is that if I talk about this, I'm gonna die like next week. So what are some other myths or misconceptions surrounding ACP?
Yeah. If, I think a lot of people get afraid, like let's pick on, advanced directives. You sit with a lawyer, these advanced directives. Most of them are very generic, and it says, if two doctors say that I am terminal, you can withhold or withdraw things from me. Well, people think if you write that down and you get to a place where you're thinking about having a do not resuscitate in place, everyone's going to stop taking care of you.
Mm-hmm.
So I can't talk about this because if I say that, you're not going to do all the other things. Like, I'm not going to get antibiotics. I'm not going to be able to go to the doctor anymore. Wait, you're going to throw me out of the hospital. And I'm like, what are you talking about? Right? It simply means if you die, we're going to let that happen as natural as possible. Like I started just saying that to people, like, listen, a do not resuscitate is talking about you're already dead,
Yes.
undead, if that is not what you want. But I'm going to do all the things to try and stop that from happening. And
Mm-hmm.
it doesn't take any of that. Um, so I think that's a really hard concept. And I'm going to admit it's not just for the lay people. I think it's for some healthcare folks,
Mm-hmm.
it's a concept because I'll see people sometimes and we'll talk about care plans, and there will inevitably somebody on the team who's like, well, why are we going to do that? They're a DNR. And I'm like, what are you talking about? Like, of course I'm going to do that. Like DNR doesn't mean do not treat.
Do not treat exactly.
Right,
It's
right.
it's
So
DNR, not
oh,
DNT. It's like,
correct.
wow. Okay. This is why education is so important.
Yeah.
Yeah,
Yep.
like and having these
I
conversations.
think it's so much, yeah, it's so much educating people and just it's like modeling the behavior. It's
Mm-hmm.
allowing to see those things play out or see conversations. I'm a big one when I'm seeing folks in the hospital. If I have a nurse who seems like a little interested or scared, right? Like, oh my goodness, I don't know what's happening. I'm like, listen, come sit with us. Like,
Mm-hmm.
come to the conversation. I want you to hear what the patient is
Yeah.
telling me. I don't want to be the only one to hear it. Like, they should be able to share that with everyone taking care of them.
Mm-hmm. I completely agree. So, what are some of the effects or impacts that you have seen on families who have not had the conversations?
Oh, yeah. I mean, I'm sure you've seen the same. It can be really devastating
Mm-hmm.
um, to a family that the patient, has not any thoughts, has not vocalized anything because it's confusing, um, it's scary, and they're already in this heightened sense of this is the worst, day, week, month of my life because
Mm-hmm.
the person is sitting in a hospital, unable to talk to me and tell me how they feel, that they don't even have a sense of, does my person think that this is suffering to be sitting in a hospital bed like this?
Mm-hmm.
And then all of these strangers on the healthcare team, just continually asking you questions. And I think again, it's a setup for all of this fear to come. People get very, I hate using the word defensive, but it's defensive from a protective sense.
Mm-hmm.
I see it manifesting as avoidance, where it's like, okay, I'm just going to avoid everybody so no one talks to me about it. Nobody asks me any more questions, and they can just keep taking care of mom, dad, my husband, my wife. And the healthcare team is like, what are we doing? Like, we need to have a conversation about.
Mm-hmm.
Um, and I think ultimately, whether there's a good outcome or an outcome that leads to the person dying, it sets people up for this really complicated grief process because they're just coming from it from a place of feeling guilty
Mm-hmm.
and being able to get to a place of acceptance.
Yeah. It definitely is something that I see way too often
Mm,
because unfortunately in our society we are not so comfortable talking about that. Um, People are okay. I think people are okay to plan their funerals, but they're not
mm,
okay to talk about, okay, how do I want to be treated
yeah,
coming on to
yes.
the end of life? And I can't wrap my mind around it, but
Mm,
okay, I understand, everybody has their quirks or what have you.
yeah,
Um, but I just like you, I've seen the devastation
mm,
of family members after that person passes. And like it's like what could we have done differently, right? And it's just had had some conversations is what could have been done differently. Like we're not asking you to come up with a treatment plan, like that's we're going to do that,
right,
but we
right,
just need to know, what do you want, what does your loved one want?
right.
Because we might see them today, and then next week they might have a conversation with you as their proxy,
Mm-hmm.
saying, I've decided that this is what I don't want anymore. So then we're relying on you to give us that information because we're not there with them as often as you may be as the family member, caregiver, what have you.
Right,
So
right.
yeah, I definitely have seen that. What you described about people avoiding, definitely seen that as well.
Yeah,
And then after the death, the guilt that comes with
yep.
it, is, yeah.
And have you ever, I like how you mentioned like people plan for their funeral, but they don't
Mhm.
plan for how you're going to get there, right?
Yeah.
Which is wild because tons of people will plan for a pregnancy or like I always liken death to birth. And I'm like, you plan for a pregnancy, or even if it was, a surprise, you're still planning for those 9 the baby to come out. But when we have the ability to recognize that we may be closer to the end of life, we don't want to plan for how that's going to look. I'm like, our body's really smart. No matter what we do, sometimes our body is moving towards death.
Yeah.
It's given us signs. We're just not listening.
We're just
I
not listening.
people, and I've said, have you ever done advanced care planning or a living will or talk to anybody about, how you would want kind of things to go? And I always laugh when the answer is, oh no, I've done all that. Like my son is getting my house and my daughter's going to take care of all my money and my bank accounts. And I'm like, no, I'm not talking about that. I said, I'm not talking about when you're not here, I'm talking about when you're still here. How are we going to get to that place? And
Exactly.
it, I, I think for some people too, um, they've never been asked, so they never realized that they could have the power to participate in that.
Hmm.
And I think as part of the healthcare team, like that's what we need to give back to people. Like you have the power to participate in the planning for this, and it's kind of your job. Like you're driving the bus. Like let me know how I can help you.
Hmm. Yeah. So, what would you say if you had to advise somebody, even somebody who, as you said, you have had the conversation with your husband and your children. So, even for somebody who's not ill, what advice would you give them to just as a first step to broach the topic of advanced care planning?
Yeah, that's a hard one. I think um again, I think the most important thing is to talk to a person, whether it be a spouse, a child, a parent, a best friend, someone that you know matches up with your values and will listen to you, right? And I think it's totally okay to open the conversation with, hey, listen, I want to talk about something that maybe is a little weird, or, maybe it's going to be a little uncomfortable, but I really want to talk to you about this. And then say, if something were to happen and I was in a really bad place and couldn't speak, or I was really sick, I want you to know what's important to me. And that
Mhm.
may be all it takes at that point. Like I don't think you have to sit down and have a marathon conversation for 2 hours and be like, okay, I want this, and
Let's
if
bring out notebooks and pens.
I want every little thing. I'm like, I think in the beginning it's just, hey, I need you to know that you're my person and I want you to be comfortable talking about this. Because how
Mhm.
many times where you've been in the same situation where you're meeting a person and you meet their family and inevitably, the family you at a time where they're patient and family says, I really want to talk about this, but I'm just so afraid to bring it up with them. And then you go talk to the patient another day, and the patient's like, I really want to talk to my husband about this, but I don't want to hurt his feelings. And I'm like, you're
Mhm.
both the thing. So
Yep.
it's really just, listen, it's gonna be uncomfortable, and you're going to put yourself in this space that is momentarily uncomfortable. Everybody brings their guard down. I think it has the potential to be, it's such a beautiful space to be in when you trust somebody with those thoughts and when
Mhm.
you're that they trust, right? I've
Yeah.
had a friend and say, I don't have anybody else. I need you to be my healthcare proxy. Okay. Do I know every little thing that he wants? Not yet. Like, we're cool. Foresee him having an issue with her. But have we already established that every once in a while, like, we just stuff, sometimes something in the world, someone, celebrity passes, or someone else we know passes away, and it brings that conversation around again.
Mhm.
We may be talking about vacation, and then it comes around, oh, did you see so and so died? Um, and I heard this happened. Listen, if that ever happens, don't let them do that to me.
Mhm.
Those that it's comfortable. You can talk to me about it. So sometimes it's just breaking the ice. Just break the
Yeah. One of the ways that I thought about while you were speaking was sometimes you could be watching a movie. Like I found that there have been some touching movies recently with persons, coming to the end of life, especially
Mm,
younger people who and they're in a relationship and they have to have the conversation. So it's like, you could be sitting watching a movie with that person and
yep.
a similar movie and just be like, what would we want in a
Hmm.
situation like that? Like, so yeah, I agree. It doesn't have to be this huge production. It could just
Right.
be, yeah, have you ever thought about what we would want, what you would want? Thing?
Mhm.
Do you think you know what I would want type of thing? Yeah. Okay. What would you say are any systemic barriers that exist in your setting that make advanced care planning difficult? Sorry, more accessible and meaningful for families.
Oh, that make it easier.
Yeah.
Um, I think, oh wait, I'll back up. One thing I think that is difficult is that
Hmm.
as healthcare providers, time is of the essence, right? So I think it's difficult because not a lot of providers have time to sit and talk things with
Hmm.
families. But at the same time, I think it is becoming a little bit more uh, accepted. The internet helps. So people are learning the buzzwords like advanced care planning, healthcare, palliative care. So again, folks are talking about it more and putting the providers in a space where it's like, hey, I want to talk about this.
Hmm.
I also think that people seeing multiple providers, I have a kidney doctor, I have a heart doctor, I have an oncologist, I have, all these things is opening up multiple avenues for those discussions to take place.
Hmm.
But then, admittedly, the barrier is all of those things speaking to one another. finding a way that if you tell your cardiologist something, the cardiologist has to make sure that you're telling all your other doctors the same thing. Um, but I think it sounds silly, but I think social media and the internet are really helpful ways because it pushes people to ask for things. And
Mm-hmm.
one way as like, I have a father-in-law who love him to death, loves to go to the doctor, right? If he could just,
Mm-hmm.
it's like a notch on the thing, like, woof, I have a cardiologist. So, so it's like if one more thing. So, hey, you know, you talk to your doctor about this. Oh, I'm going to talk to my doctor about this. And social media really accomplishes that. And then if people think like this thing that I deserve from my doctor, like I have Medicare and Medicare, I should talk about advanced care planning. Well, I'm going to talk about it. Um,
Mm-hmm.
so I think that those things can all be as an advantage. I'm just not sure that we have figured out how to do it perfectly yet.
Okay. Okay. And that actually goes into my next question for you. What gives you hope for the future of advanced care planning and compassionate care?
Yeah. My hope, I think going back to what I said before, is that the public at large, the general public, the regular people who are not healthcare clinicians, providers, learn more about the importance of it and about how empowering it can be
Mm-hmm.
to be able to share your needs, your wants, your goals. And I think it's going to be that movement. It's going to be the patients and the loved ones who are going to put the very needed pressure on all of us to
Mm-hmm.
be, this is something that we deserve. So now you have to provide it. I'm sure it's very similar where you are. Like, there are not enough palliative medicine people anywhere to take care of the amount of patients. Yes, all of our lovely colleagues, every other, whether it be cardiology, oncology, nephrology, should all be practicing using their primary palliative. No reason why your nephrologist can't say, "Hey, have you thought about, what if things get worse? What are we going to do?" You
Mm-hmm.
know, but I admit some of them don't like doing it or it just doesn't register thought that way. So you can use your palliative care folks. It's just that there's not enough of us. But I
Mm-hmm.
think if patients and families realize that this is available to them, that they're going to be the impetus to be like, I want this. And if they
Mm-hmm.
keep it, then they have, hospitals have to hire more of us. Like
Yeah.
we're just that we are necessary and as a full package of healthcare.
Mm-hmm. Yeah, totally. In Barbados, there are
In Barbados, you are,
hardly there there are hardly any palliative. Like if
oh
I put
man.
up 10 fingers and I brought down the one family, I'd have fingers left back. Okay, so that that's the situation that we're in, and we have a population of 280,000 people, and
Wow.
we have an aging population
Mm,
and all the things that come along with that. So we really do need, in our setting, to have a greater push. We really are trying to educate more primary care physicians
yeah.
in palliative care because, as you would know, you don't need to have a palliative care specialist specifically
Hmm.
to be able to deliver quality palliative care, right? It's
Yep.
it's it's not hard. Yes, we can give the input. Yes, we can assist. Yes, we can be there if your primary care physician has a question, but
Mm,
it's easy for them to become trained in at least basic palliative care so that they can recognize situations and be able to start the conversations and to
yeah.
manage you effectively as needed. So, Tracy, Where can people find your work or connect with you if they wanted to?
So LinkedIn has been awesome lately.
Mhm.
Obviously, we all
That's right on you.
I LinkedIn has like been on fire lately. So I think LinkedIn is great. Um, Instagram. So my Instagram is on LinkedIn too. You can find me there. It's like
Mhm.
your.if_PA. I try and
Uh-huh.
put stuff too. Um, the other important thing too is I'm the current president of PAHPM, which is PAs in Hospice and Palliative Medicine. Our
Mhm.
website has resources for, you know, colleagues, healthcare providers, PAs, but also for patients and families who are just wondering, what the heck is palliative care? What does that mean?
Mhm.
Um, so yeah, I think public facing education is super important and
Totally.
conversation, wonderful because we show that it's not terribly scary. I think taking the fear out of it is the biggest thing.
Mhm.
Um, and just being able, it's like you said about primary, trying to teach the primary doctors to have the skills to do just a little bit of it. I think a
Yeah.
lot of importance of that is, listen, you're going to your primary doctor. Some people have been seeing their primary doctor for 15, 20 years. Who better to talk about this with than some,
Correct.
as opposed to me meeting you for when you are already under stress and being the first person to say to you, let's talk about what happens if you're closer to the end of life.
Mhm.
Because we're not friends yet. We haven't gotten there.
Correct. Correct.
So,
Yeah. Well, thank you so much, Tracy. I really, really enjoyed this. It was a great conversation. It was also very, very informative. I'm sure that everybody listening will take some serious nuggets from it. And I hope that it prompts them to, regardless of their age, regardless of their health status, to take those steps to start their advanced care planning because you just never know. You really just never know. So
absolutely.
thank you so much. And
Thank you.
for those of you watching, so the podcast drops on YouTube every third Thursday, the third Thursday of every month, sorry. And you can follow us on YouTube at Compass Pal Travel. We're also on LinkedIn and on Instagram. So bye. Thank you.
Thank you.